On the surface, it's one of the most common operations in the world. But for one patient, this totally routine procedure became a medical thriller, all because of an incredibly rare genetic condition that was lurking right beneath the surface.
And that right there brings us to this central question of this whole explainer. How do you navigate a complete minefield of risks when the map is for a disease so rare that, every single step is a potential disaster? Let's dive in and break it down. All right, so our story centers on a 35-year-old man. He's been diagnosed with chronic cholecystitis, which is basically a really painful inflamed gallbladder. The solution? It seems straightforward. A laparoscopic cholecystectomy, which is just removing the gallbladder. But this patient, well, he is anything but straightforward. Turns out he has Andersen-Tawil syndrome, or ETS. Now, it's a super complex condition, but you can really get your head around it by remembering this triad of symptoms. First, you've got periodic paralysis, these sudden, scary attacks of muscle weakness. Second, there are dangerous heart rhythm issues. And third, you see these distinctive physical traits, like a small jaw and wide-set eyes. And all of this, it all comes from a faulty gene that just messes with the body's potassium channels. Okay, so this brings us to our first section. To really understand the risk here, you've got to understand the patient's journey leading up to this exact moment. This timeline really shows just how high the stakes were. I mean, look at this. In the last 2 years alone, the patient had 4 severe paralysis attacks, some lasting up to 12 hours. He's also had 2 fainting spells. But the real flashing red light is on his EKG, a QTC interval of 470 milliseconds. To put it simply, that is a huge red flag that his heart is taking way too long to recharge between beats, putting him at an extremely high risk for a life-threatening arrhythmia. And now, he's about to go into the stress of surgery. With stakes this high, you just can't wing it. No way. Success depended entirely on meticulous, almost military-grade mission planning by a whole team of specialists. And this was the team. Seriously, think of them as a medical special ops unit. Neurology was on point to prevent a paralysis attack. Cardiology's mission was to shield the heart at all costs. Endocrinology was there to make absolutely sure no other hormonal issues were in play. And anesthesiology, well, they had maybe the most complex job of all, designing an anesthesia plan that wouldn't trigger a total catastrophe. The pre-op phase was this incredibly delicate balancing act, kind of like walking a tightrope. You can see right here, his potassium was a little low, so the team gave him an oral supplement just an hour before surgery. His magnesium was also low, so that needed an IV infusion. The goal, of course, was to get every single one of these values into that perfect target zone before he even set foot in the operating room. And why was this so critical? We'll get this. The data is crystal clear. Meticulously optimizing potassium and magnesium before surgery has been shown to reduce the risk of life-threatening arrhythmias by a staggering 70%. This wasn't just being cautious. This was evidence-based, hardcore risk reduction. Okay, so now we're stepping into the operating room. With the patient perfectly optimized, the next huge challenge was choosing the right path through the anesthesia maze. One wrong turn, and it could be fatal. The single most crucial decision the team made was about the type of anesthesia. Standard inhaled gases were a total non-starter for this patient because they can prolong that dangerous QTC interval. So instead, the team chose total intravenous anesthesia, or TIVA. This method keeps the heart nice and stable and has this awesome bonus. The patient wakes up super fast, which lets the team immediately check for any signs of paralysis. Just as important as what they did use is what they strictly avoided. Succinylcholine, a pretty common muscle relaxant, was absolutely forbidden. It can cause a massive, deadly spike in potassium. Dextrose solutions were out too, because they can make potassium levels totally crash. Every single drug was scrutinized for its effect on his delicate potassium balance. And this, right here, was the custom-built protocol, a step-by-step plan designed for maximum safety. From a little sedation to start, to a super precise induction cocktail, a steady maintenance infusion, and finally, a modern reversal agent called Sugamamodex that safely and reliably brings the patient out of muscle relaxation. Every single step was completely controlled. But, and this is a big but, the surgery itself was only half the battle. The team knew that the hours immediately following the operation were just as dangerous, maybe even more so. So even after a smooth and totally uneventful operation, the patient wasn't sent to a regular recovery room. No, he was transferred directly to the intensive care unit. And you might ask, why? Because in ATS patients, the physiological stress doesn't just stop when the surgeon puts down their tools. the highest risk for cardiac events and paralysis is often in that 24-hour window after surgery. In the ICU, that hypervigilance kicked into high gear. A continuous EKG watched his heart's every beat. They checked his lung capacity every single hour for any signs of weakening respiratory muscles. And his potassium? Checked every 2 hours. Even his pain management was totally customized to avoid drugs like morphine that could suppress his breathing.
And this is so crucial. The team wasn't just reacting to problems. They were prepared with a predefined playbook for every single what-if scenario. If potassium dropped, bam, they had an IV infusion ready to go. If it spiked, they had a counter cocktail of calcium, insulin, and glucose. For any abnormal heart rhythm, they had magnesium and amiodarone on standby. They literally had an answer for everything.
So ultimately, what does this incredible case teach us? Well, it's a lot more than just a story of a single surgery. It's really a masterclass in how to manage high-risk medical care. The keys to success really boil down to these 4 pillars. First, seamless teamwork across different specialties. Second, that obsessive preoperative optimization. Third, an anesthesia plan that was totally tailored to the patient's unique genetics. And finally, proactive post-op care that anticipated problems before they could even happen.
And you know, this quote from the case study itself really says it all, doesn't it? The ultimate conclusion is that even in a crazy high-risk condition like Andersen-Tawil syndrome, surgery can be done safely. The crucial ingredients are planning and personalization. It's just a testament to what modern medicine can really achieve.
And that leaves us with a final thought to chew on. This one case just brilliantly illustrates the power of a truly personalized approach. It really makes you wonder, as our understanding of genetics grows, how many other conditions, how many other lives are going to depend on this incredible level of detailed, collaborative, and individualized care?